Thank you, George, and I think a number of these presentations today really got at some of these issues that we want to talk about. So we're going to just talk principally about stable ischemic heart disease because, as you all know, this is where the real decision-making is very difficult. Unfortunately, I have no disclosures, having to resign from all those boards to edit this journal. What is the outlook? What's happening? It's already been pointed out that things are going south in terms of volume in interventional cardiology. And here in New York State, you are seeing a decline year over year, pretty much in volume, and it's not been replaced by surgery because you see that going down at the same time. This is probably appropriate. I think people are being more careful about the kind of cases they select. So how do we make decisions? Well, the decision making is based on the evidence. You've got this evidence that has been talked about. You know it very well. That has come from some meta-analysis, the Courage, the Barry 2, and the FAME trial about should you have revascularization or not. We'll come later to the question of which kind of revascularization. The two trials are highly selective patients. They came from many patients screened, and the overall results, you know well, were neutral. And this is an important point to think about what the meaning of trials that do not show an advantage of intervention over conservative therapy. They are not negative trials, they are neutral trials. Now, one thing I want to explore that is new about the Courage trial is you remember there was a time that we thought that the amount of ischemia did predict how the patients would do. And in the Courage trial, for sure, if the patients were revascularized, we see here on the left that there is improvement in ischemia. On the right, the patients not being revascularized, there was not a change. However, a subsequent analysis of the baseline ischemia that the people had did not show a difference in outcome based on the baseline ischemia. And that was shown in this particular study. However, the new observation is that when you look at the ischemia in the Courage trial and you compare that to the anatomic burden of disease measured by the angiogram, we see some very interesting data. Here is the ischemia based on thallium, 0 to 5% ischemia, 5 to 10 or greater than 10% ischemia, and looking at this admittedly modestly low-risk group of patients with ischemic heart disease, this did not predict the outcome. On the other hand, the anatomic burden of disease measured by the angiogram did. This is a scale that I don't have time to go into, but it's similar to what had been used earlier in the Barry trial and all sorts of trials to measure the extent of disease. So in your practice, you make these judgments about this is a patient with a lot of disease and angiographically, and perhaps that's important prognostically, and this would support that. So the question is it function, namely the amount of ischemia, or is it form? And my conclusions have been that it's probably both, and that'll be important thinking about future trials to investigate how we make these decisions about our patients. Now, the Barry 2D trial of diabetic patients, of course, was another trial that showed comparable outcomes of invasive therapy versus conservative therapy. And in that trial, you could have surgery or PCI, and because of that ability, most of the patients with triple vessel disease had surgery, and all the patients with single vessel disease had interventional therapy, and the trial overall was neutral. The patients going for surgery were much higher risk, so the medically treated patients going for surgery had medically treated patients in the surgery cohort had a very high event rate compared to the medically treated patients in the PCI cohort. So we selected the harder patients for surgery in this trial. And the one bit of information that supports the idea that maybe revascularization is worthwhile was in the highest risk group of patients who did receive the surgery, or in the surgery cohort, but those patients who had intervention, revascularization, did better than the patients treated medically. Here's a blow-up of that same outcome. So from these, from COURAGE, we know that the patients with the most extensive disease had a worse outcome. We know that patients from Barry 2D with more extensive disease seem to benefit from revascularization. So the other trial that deals with this is the trial utilizing FFR, where patients are randomized in the famed trial either to, if the FFR was normal, there was not obstruction, then the patients were treated medically, even though they had lesions that were considered for intervention. And if they had a positive FFR, they were randomized either to PCI or to medical therapy. So in that trial, the patients who had no obstruction had a very good outcome. Cumulative incidence of these adverse events were very low. If the patients had a significant lesion measured by FFR but did not have intervention, you see the event rate was quite high. If the patients had intervention, it was very low there. So it supported this idea, but the criticism was that most of these interventions were driven by repeat intervention because of symptoms. But you can imagine that patients who know they have lesions, the physician knows they have lesions, and they were not revascularized, might have more of these events. But had this trial gone to completion, it was stopped early, it is quite likely that death in MI also would have supported the idea that intervention was beneficial. So there are two views of evidence that we have in our decision making. One is that since the new approach, the interventional approach, was not proven superior, that we shouldn't do it. The other approach, however, is that since neither was shown superior, that judgment for these kind of patients is important. So equipoise is not so much that we don't really know or don't have an opinion as to which is better, it's that we don't yet have the evidence of which is better. The real thing we'd like to do, as Dr. Narula talked about this morning, is identify the patients who are going to have events in the long term. We've got all these techniques that are very valuable, but they're invasive techniques. Thin fibrous cap was emphasized by Dr. Narula, and the question of bioabsorbable approaches to these kind of things was also mentioned. In the future, we may see that, but for our patients in the office, for the patients we're seeing, even for the ones who've undergone angiography, we currently don't have a very accurate assessment of which ones are going to have events in the future, despite all these technologies, invasive technologies, including near-infrared spectroscopy and so forth, that can visualize these lesions. Now, if it turns out that revascularization is needed, and we've seen 3 cases this morning in which the judgment was made that the revascularization was needed, which should we do? How should we decide between surgery and interventional therapy? Prior to the drug-eluting stent era, there were a number of studies that showed 10 studies that showed with balloon angioplasty or stenting, if you didn't have diabetes, in all those trials, there was rather equivalent outcomes out to 8 years. The diabetic population was unique in showing that, in fact, they were not as good. Here's the First, drug-eluting stent comparison, the ARCH trial, again showing diabetic patients, whether they were bare metal stents, surgery, or drug-eluting stents, had higher event rates than diabetic patients. And then the FREEDOM trial, as you all know, did show a marked advantage for surgery over patients treated with percutaneous intervention. But remember, in FREEDOM, almost 90% of these patients had triple vessel disease and diabetes. So there's a high Syntex score group that we have to admit at this point in time seem to do better with surgery. We could not find in Syntex, in FREEDOM, a group of patients with a Syntex score that said these were fine to treat with percutaneous means, but we didn't have very many patients with a low Syntex score. In the Syntex trial itself, patients with the lower Syntex score did equivalently well if they were diabetic patients. The intermediate and high Syntex score patients did better with surgery. We know the other things from Syntex I won't, for the sake of time, dwell on, but it supported left main intervention. We saw a patient this morning, the suggestion the patient had left main disease. The point was made that the patient was recommended for surgery but didn't want it. I don't know how strongly anymore we recommend surgery for all the left main patients, because now left main is not a contraindication for intervention. In fact, in many cases, is the preferred method. Triple vessel disease, on the other hand, for patients with intermediate and high Syntex score, still are problematic for us, and many of those probably should be going for surgery. So what's changed based on the evidence? Left main is now more commonly done. High Syntex score patients go the other way, and diabetes remains an important ingredient in our decision making that moves us towards surgery. So what has changed? Has there been progress in surgery and PCI since these trials? Well, surgery has not changed a lot, but PCI has. They're new, as you've heard just now, a number of changes in the second generation stents, changes in polymers, changes in drug delivery, changes in the metal, the alloys, the thickness of struts, and even now stents that are going to go away in the long term. There's some evidence to support that. Here is the latest, one of the stents that was just presented, everolimus-eluting stent, with lower event rates than the first generation stents. And so the stents that were used in some of these trials, particularly in FREEDOM, we did not have the latest stent available, and maybe that will influence outcomes going forward. So how do we make decisions given all this? What do the guidelines say? Well, the guidelines for stable ischemic heart disease have changed. The last guideline, a brand new one, not a redo, but a new one that took 5 years in going through it, basically does not start with the angiogram. It starts with patients in the office, and the way you get to the cath lab with the new guidelines is through two mechanisms. One is the patient is being treated and is not responding adequately, and the other way is the patient has high risk non-invasive indicators. So those are the two ways you basically are supposed to get to the cath lab to qualify as an appropriate indication for moving forward. And that I know you're all quite aware of. This appropriate use criteria is a parallel thing. It's not replacing the guidelines. There's been a lot of confusion about appropriate use. It is a work in progress. These scenarios do put people in categories, and the category does not always fit the patient that you've got in front of you. I think it's a good academic exercise. It was never intended to be specific for any patient. It was a quality improvement measure, and was perhaps a little bit misinterpreted here in New York State, and I think this is going to hopefully be rectified in terms of fitting these appropriate use criteria, but it is helpful. Now, here in New York State, and I'm a culprit here because I'm a signatory to this paper, we did take a look at what you're doing, and fortunately we found this hospital had a very low inappropriate rate. And if you pay attention to the forms and the fill out it, you can get a pretty low rate. This other side of this coin, though, this study from Canada showed that if you have appropriate indications by that appropriate use criteria and you don't revascularize the patients, then you have actually higher event rates. So there's another side to appropriate use, that if the patient is appropriate for intervention and doesn't get it, that may result in adverse outcomes. The real approach that I favor is not a new approach. The heart team approach we talk about as being new, but the heart team approach, consultation with colleagues, has been around forever, and the composition of heart team and how it's applied varies on every case. But for the more complex patients, the utilization of the medically treating physician, the interventional cardiologist, and the surgeon to help the patient make the right decision is, I think, very important, and it's emphasized in the European guidelines and the American guidelines as a very important approach to this. So the contrast between appropriate use, which is sort of a lumping of patients into categories, and the appropriate and the heart team approach, which is a splitting of the patients into infinite number of groups, with each patient being their own group and bringing multiple opinions, is my favorite way to make decisions. We have to realize that patients have different concept of what we've presented to them. This paper is a bit dated now, but it's one of my favorites. It points out the fact that patients' expectation is very different from what we've told them. The physician, either the interventional cardiologist or the clinical cardiologist, might have predicted that their patient undergoing stenting had very low chance of reducing mortality. The patient wants to believe that that was the reason for the procedure. The same is true for preventing MI. All the people questioned, both physician groups and the patient all agree that it was to relieve symptoms. The question is, as we inform our patients, how do we, I'm going to skip this case because it doesn't add much. The question is, how do we really inform our patients about what they should do, and where will the new evidence come from? The trial that is ongoing, the Ischaemia Trial, is aiming to address this. This is to take your patient at the office level and say, who should move on to revascularization with stable ischemic heart disease? And it's looking at the patients from the perspective of the ischemia that they have. I'm a little concerned about this because the angiogram is left out of this formula. And so at some point we have to decide who's going to go ahead and have an angiogram. So whereas the function, the amount of ischemia may be highly predictive of future events, as I've shown you from a sub-study of courage, the anatomic disease is also important. So the decision-making about who goes to the cath lab remains a work in progress. CTA is coming on board. We're going to know more about anatomy from that than we did before. And so I think the integration of anatomic information and ischemia is going to be helpful as we make decisions in the future. So here's my final slide. In decision-making, a number of things are different. Doctor knows best. This is no longer works. We can't just say, I know what to do with you, therefore you should do it. Patients are now questioning us. Patients often want a second opinion, so why not get it up first? This is the heart team approach. Patient told, hey, we've considered your situation. It is the one that is complex. Surgery could be done. Here's the surgeon, here's the interventional cardiologist. We've decided that together that this is a good decision for you. This would be helpful. Or informed consent is often not informed, no time to go into that, but you need to reflect on the fact that what we tell patients is often not assimilated. Patients' expectations frequently differ from the doctor's. However, eliminating the art of medicine, taking away the patient's expectation of a good outcome is also problematic. Thank you very much.